Good afternoon, and thank you so much, Dr. Anaga. It's a privilege to be sitting among the elite of today's cataract world, and of course, refractive. My topic is relatively very simple and something that will directly relate to your issues day to day. It deals with common mistakes. Sometimes they are too common to be mentioned, but still, they need to be mentioned because once in a while, even for a senior surgeon, when you're not very attentive, such things do happen. Now, we know that cataract surgery is broken down into different steps, and each step you have done thousands of times. But in part of that, sometimes you can land up with problem. Like incision, rexis, they say your good phaco builds up on each stage one after another. And if you fault in the first step itself, your final results are always substandard or subnormal. Now, if you just have to look at this incision, if by chance your keratome is not sharp enough or it is too sharp, whether it's double bevel or single bevel, whether it's anteriorly placed or posteriorly placed, sometimes you may get a longer incision or sometimes you may get shorter incision. Both the times it creates problem. So if it's a long one, you have bad overlocking that needs to corneal folds. So once you know when you're making a longer one, you think your incision is becoming a little longer than your comfort level, then you can always come back a bit and redo it. Now this way you are able to, but sometimes if you land up making too short a one, then you always have an issue that it's going to cause you problem halfway through your procedure. Second important thing, if you watch carefully, it's when you're staining it. See, when you stain, your tip is not visible. Not that it happens often, but it happened to me very recently, and it really caused me a lot of concern. Your cataract surgery will take you 10 minutes, but this issue itself, can you notice that? My cannula has touched the anterior capsule and it has torn it at the place I would not really would have liked. Now, what do you do? Now, these are the mistakes where if you can treat it right then and there, meaning you'll have to entirely change the course of your action. And sometimes you get better visibility. You can always use your oblique line because you need that illumination, visibility, not illumination, the visibility, that particular corner, because a critical step, your cut is almost going to the periphery if you can't stop it there. So you may have to go with the micro scissors, you may have to go with the forceps and try and create a continuity in your rexis. That's very essential. And then what I do, once I have done that, I have to get it back. So I go with the micro scissors through another side port, a very awkward position for you to carry on, and then hold on to that with the micro forceps and complete it on the other side. So that means a surgery which should have been absolutely uneventful now becomes a major issue in which the major part of it is taken over by the rexis. And then by now the pupil is small. So in a small pupil, if you have to do phaco, you are in for larger trouble. So you create you use these hooks to make a sizable sized rexis opening, and then continue with your phaco, because phaco after that becomes it's easy, and eventually you get your hooks out and carry on with your. Now this is a case I often show, but I always like to show it because this is a common mistake, not with the novice, not with the seniors, but someone who's just learned and very confident. Sometimes a beginner, after doing 100 good cases, he's little more confident. That's when the complications start occurring. If you notice what happened here, is something that could have been easily avoided. His settings never change, and the way he's holding it, your phaco tip should be buried into the nucleus mass, whereas here it was on the surface of it, so it was tangentially placed. So there was a classic surge. Now what happens if a resident knows at that stage, that's the time he has to calm down, he has to lower down his flow rate, he has to lower down his bottle, and then without taking his phaco tip out, he has to push in viscoelastic. Now that viscoelastic at that time, before the phaco tip comes out, is his savior. Now, as luck should have it, This hole is a punched out hole. Punched out hole is not a problem because it's never going to extend. And then what's a safe side or safe position for your nucleus fragment? It's on the iris. So you just locate it and push it on the iris, of course, with a viscoelastic cover. And then, if the vitreous is not disturbed, only then you go with the IA. Otherwise, you inject triamcinolone. If you see some stain, go with the cutter, clean it up. Here, not much of staining happening. That means vitreous is not much disturbed. So, you take whatever cortex that can be easily taken out, then fill it, and now it's much easier way of doing. But it's still easier in this case is to have some scaffolding, have some protection. Now I've used a single piece lens for scaffolding. Normally when you have PCR and you want IOL for scaffolding, it's always a three piece. But I'm using single piece here. The reason is the PCR that I had was a punched out hole. When you have a punched out hole, you're not worried that it will extend. So I can always get my lens back into the bag. So what I do is at the end of it, again put some hooks, open it up, get the lens into the bag. Now, this is very common. Remember, as an ophthalmologist, we are tissue surgeons. When you're a tissue surgeon, you have to respect the tissue. Now, these side ports. Now, imagine if with a bimanual, without changing hands, when the surgeon wants to literally, try and get it out, one thing you kind of, disfigure the side ports. And the side ports, if they are tight enough, they'll close much better without much of hydration. Here in the process, what happens? Because the vacuum and aspiration flow rate is little on higher side, the PC is caught. This is very common. So that means you have finished your surgery very well. You're so happy, and then for very pesky reason like cortex, you get this PC. But if luckily that was a small one, so nothing much will happen. But if it's little bigger and a cortical thing falls in, you're honestly worried. So what I share with you is a small twist. The twist is this: respect your side ports and make a mental this thing that you won't cross the midline. If you're on this side, you'll only do the opposite side, but all the time remembering that your side ports are not disturbed. Then I change my hands. And even when the instrument goes in, respect your tissue. See, it doesn't hurt to respect your tissue. But at the end of the day, if you want your corneas to be pristine, clear, you have to respect the tissue. Now, I have given enough respect to the tissue, meaning the side ports. My surgery is almost over, and now it's time for me to put the lens. So what happens? After the lens is put in, I just flush it. My side ports will never leak. See, just flush the floor and your wound is closed. Why? That's because your side ports are taken care well. Sometimes, in fact, in my practice, I never do hydration. Wound hydration is never done in my practice because I only hydrate the floor, and it gives me excellent. And with hydration, you have a little bit whitening of the cornea. It never occurs. Now watch it carefully. At the end of the case, your cartridge has not really gone into it. You're not angled well, and this is what happens. Now, if you're lucky, and if your lens is only 1/3 in, you can easily pull it out. But this is a problem. So sometimes you have to literally pull it out. You can't push it in, by the way. You can pull it out. When you pull it out, sometimes there are scratches, sometimes there are the haptic tears. So for that, you have another good way of doing it. Now here, the lens is going in. But you know that something is not okay right at that time. So instead of pulling it out, because your cartridge is also giving you some amount of pull, go with the forceps, just press on it. Now you have two instruments pulling it out, and the lens comes out, and the same lens can be implanted because it is not damaged. Now these are very simple ones. Now look at that. Sometimes, if your settings are not good, if you have misjudged your floppiness of your iris, these are the problems you'll end up with. It doesn't matter. If you are in the beginning of the stage, You can treat that iris well. Now, in this case, if I had to start from the beginning and if I had seen the floppiness, I would not use a ring, but I would use a hook. And the first hook would be in a diamond shape, where the first one would be under my incision to take it away from my incision. Anyway, this has occurred. So next time, if I don't want it to happen, what I would do is, at the end of the case, a multifocal or a trifocal lens is put, and the iris shows its floppiness. What I do, I just inject a little bit of viscoelastic because that's very necessary to push it back. And then I go with a second instrument through the side port. Maybe again, I'm hopeful that just the visco will take care of it, but not always. So here I see it's not happening. So this is the time when I don't want to wait anymore, because I do not want to see my patient 6 months later with a depigmented iris there. Very often a patient comes for a long follow-up, operated by someone else or you, and you see those white patches there. That's not good. So here what I do, I go with the instrument, try and press the iris back. Beautiful it stays. No more floppiness, no more prolapse. So these are very, very simple things that you can do. And thank you so much.